So welcome, thank you guys for joining us. This is a webinar training on the topic of trauma and post-traumatic stress disorder, looking at manifestations and consequences for persons with psychosis or other serious and persistent mental illness. This webinar is being facilitated by Dr. Jennifer Gottlieb, who I'll be introducing in just a moment. My name is Sarah Kapelovich. I'm a clinical psychologist and assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington. And along with my colleagues at the UW, I'll be hosting this webinar today. So just a reminder before we get started, the webinar today is being recorded and portions of this webinar will be made available online at a later date. Before we dive into the topic, I want to take an opportunity to familiarize you all with a new resource in really in the United States and also in our region. So the Substance Abuse and Mental Health Services Administration recently launched the Mental Health Technology Transfer Center Network. This includes a network coordinating office, which is at Stanford University, 10 regional mental health TTCs, a tribal affairs center at University of Iowa, and an Hispanic and Latino center in Puerto Rico. And the collaborative network is going to be is now supporting resource development and dissemination, training and technical assistance, and workforce development to the behavioral health field throughout the United States. Our goal specifically in the Northwest, and you can see our region of the country covers Washington, Oregon, Idaho, and Alaska. Our goal is to provide training and TA in evidence-based practices for individuals who have or are at risk for serious mental illness. So at the end of this webinar, I'll be sharing some ways you can learn more about our training plans, the resources that we have or will have to offer, and trainings coming up in each of these 4 states. So just a quick reminder before we launch into the meat of the webinar that our language matters, so we strive to use person-first language, which emphasizes the person over the disability or disorder or other status. None of us are defined by a diagnosis or a life experience. So we'll be using phrases in the webinar like a person with schizophrenia or a person who has experienced trauma to make sure that the language we use is consistent with those values. So without further ado, I'd like to introduce today's trainer, Dr. Jennifer Gottlieb. Dr. Gottlieb is a diplomate in psychotherapy. She's a clinical psychologist and a faculty member at Boston University. Her research and clinical work is dedicated to the development and implementation of effective psychotherapeutic interventions for psychosis, schizophrenia, and other severe psychiatric conditions. Dr. Gottlieb serves as vice president and is a founding member of the North American CBT for Psychosis Network. She's provided CBT clinical training, consultation, supervision, treatment implementation guidance to therapists and administrators in numerous mental health agencies locally, nationally, and internationally. She earned her doctoral degree in clinical psychology from the University of Montana, completed her clinical internship at the University of California and the San Diego VA, and has been on the faculty at Massachusetts General Hospital, Harvard Medical School, and Dartmouth Medical School. So without further ado, I'm going to turn things over to Dr. Gottlieb, and just a reminder that we'll be breaking for 15 minutes at 10:15, and then we'll be stopping the webinar around 11:50 to give you all an opportunity to complete a quick evaluation.
Thank you, Sarah, for the introduction. Let me just make sure this is doing what I want it to do. Can you all see that?
Yes. Yep.
Okay. And it's large, right? I've got it
Yeah.
enlarged. Okay, good. Sometimes it's hard to tell. Okay. Great. Well, hello everyone out there in the haze of the World Wide Web. Glad to be here to be able to do this with you all. We're going to just kind of launch forward. So this is going to be about 2.5 hours. And we are going to take a break on or around 10:15 your time. That might vary just a little bit kind of based on what we get through here. But let me give you a little bit, oops. There we go. Let me give you a little bit of background about what we're going to do today. And this is going to be largely didactic, mostly because it can't be too experiential since we're on sort of like a closed circuit TV situation. So there's not too much interaction we can have. That said, if you have a question, I will pause at certain times just to see if people have questions or comments. And I think Sam is going to help me kind of navigate those. And then there's going to be one part when we talk about challenging our own cognitions about approaching trauma with our clients who have serious mental illness, where I'm going to ask you all potentially to type in some things, all that that are fairly anonymous, but so I'm going to ask you to do that, or just write them down on paper, and just so we can kind of share some thoughts together at that point. But so here's what we're going to be doing today. I'm going to start with some definitions and criteria to kind of just get us all on the same page, get us in the mode of trauma and PTSD, and really kind of being clear about what that means these days. And then I'm going to be talking about how that looks, what that looks like in people who have psychosis and other serious mental illnesses, and the consequences of trauma and PTSD in people with these conditions. We're going to do I'm going to talk about a brief case study, which should help to bring this all to life. And then, as I said, we're going to talk about our own thoughts and beliefs related to addressing trauma with the people we work with. And then at the end, I'm going to talk very briefly about some effective treatments that have some good research backing related to working with people in this population. And then I'm going to talk about how to effectively screen using specific materials to help reliably find and understand the existence of trauma and PTSD in the clients you work with. So that's going to be our basic approach for today. And as I said, you know, there'll certainly be time for questions throughout. And at the end, we've got some time reserved as well. So let me just kind of go forward from here. Okay. Okay, so first, defining the problem, because I think we all need to be on the same page about what we're talking about when we say SMI or trauma or PTSD, things like that. So let's understand a little bit what that is. So getting on the same page here. When I am using SMI, which can also be termed as SMPI, SPMI, serious and persistent mental illness, these are the things that I'm talking about, right? People who have a schizophrenia spectrum disorder, like schizophrenia, schizoaffective, psychosis, NOS, bipolar disorder, severe and chronic depressive disorder, and borderline personality disorder, right? Those are the sorts of diagnoses that we're talking about when we're referring to people who have serious mental illness. In addition to those diagnoses, and this really varies, kind of like the technical definition to receive certain services and resources varies from state to state and region to region. However, basically, there's usually a piece of this that involves that the person has this diagnosis and this set of symptoms to such a degree that the symptoms are very chronic and severe, and their condition really impacts and impairs their overall ability to function well, to work, those kinds of things. And again, that varies, but that's really what we're looking like. And one thing that I think we want to be clear about today is, as we're going through, and I'm going to be talking about different instances of this and case examples and how this works, be thinking about your own clients who you treat at North Sound, because I think you're going to see a lot of your clients in some of the information I present, which is important, and why you're here and why I'm here. So do keep your own client caseload in mind as we're talking about this. Okay, so again, just some definitions here to really get us on the same page. When we're talking about a traumatic event, you know, the fact of the matter is there's lots of bad things that can happen to a person. Scary things, difficult things, things that stick with you in life, all that kind of stuff. But when we're talking about kind of the clinical definition of a trauma, which is what we are focused on for the purposes of today, it kind of it must meet this criteria. So with DSM-5, they've added a couple of pieces here, I think, to better define it. Now, we know that the most common way or the most upsetting way that traumas happen is that the person themselves has direct exposure to it. However, witnessing is a big piece of it as well, especially when we're talking about a child in a situation where there's a domestic violence between her parents, that kind of thing. Indirectly also counts, so to speak, learning that a close friend or relative or a loved one had direct exposure to a trauma. And then this last one is often in the course of professional duties like EMT, military, things like that, repeated or extreme indirect exposure to adverse details of that kind of event. So that's what we're talking about when we're talking about a trauma. And you know, that might have been the way that you were thinking about it too, but just to be clear, this is DSM sort of stuff that we're dealing with. Okay, so common traumas related to PTSD. This is kind of like the big list here. Of course, there's more nuanced ones and other specific ones, but these are kind of the main categories, so to speak. And as I said, you know, it's really important to remember that trauma is not necessarily anything bad that happens to a person, right? And even if someone does have a trauma, a real quote unquote DSM traumatic event, that does not mean that they have PTSD or that they're going to go on to have PTSD. Many people have experienced a traumatic event or a couple traumatic events, and by and large, they do not go on to develop PTSD. So we want to keep that in mind, that trauma does not equal PTSD necessarily, and you really have to kind of be in the DSM zone to have your event categorized as a traumatic event. So hope that's clear to everyone. Okay, let's talk a little bit about the symptoms, because I know, you know, all of you obviously are in the mental health field and you've studied and you have a lot of experience. However, sometimes it's nice to just have a review of criteria, especially if this is not criteria that you all are using in a regular way in your own agency. So I just want to go through this. Plus, this is DSM-5, and the DSM-5 criteria for PTSD has changed a little bit. I think it's improved in my opinion, but like anything, there's controversy related to it. But anyway, these are the 4 symptom clusters. So first, you have to have a traumatic event in the way that we just discussed, and then you have to have certain number of symptoms from each of these 4 clusters. And I'm going to go through and talk a little bit about each of the clusters right now. So the first one is re-experiencing, and you need to have one of these to meet criteria for this cluster. And so this is all the stuff, the way in which the trauma comes back to the person, right? And you can see here there's a variety of ways, from just memories of the event or distress when seeing a particular part of the event, even if it's not totally related, like driving by a school and becoming physiologically reacted, meaning anxious or heart pounding or sweating, if someone had the trauma where they were assaulted at school as a child. That's that kind of thing. All the way to the other end of the more severe end of the continuum, which is related to flashbacks and things like that. So that's re-experiencing the trauma, and we see that a lot. I mean, that's what PTSD largely is, right? Is the person having that trauma repeatedly played out in their mind or portions of it in a way that causes a lot of distress. So that's the first one. And then the hand in hand, unfortunately, with the re-experiencing is avoidance. So because of the distressing nature of the trauma itself, makes perfect sense that the person would want to or would be compelled to or even unconsciously would be avoiding thoughts or feelings related to the trauma or related to external reminders. So that person who was assaulted by a school likely would change her route to drive to work or to drive to the doctor so that she would not pass by any schools, that kind of a thing. So avoidance and re-experiencing really do go hand in hand. Then there's this overreactivity piece, which is kind of some extra stuff, is how I like to think about it, that people experience as a result of PTSD. So this cluster is a little bit diffuse or diverse in what it contains, but it's anywhere from being really jumpy, watching your back all the time, not wanting to sit with your back against the door, getting startled really easily by loud noises. And you can see how those things are related to having trouble concentrating, sleep disturbance, which is a major, major problem for people with PTSD and a trauma history, and then on down to other sorts of kind of quote unquote acting out sorts of things, reckless behavior, risky behavior, being really irritable, aggressive behavior, that kind of thing. And then finally, and this is the new piece that's been categorized by the DSM, and I think this is really helpful because it really helps kind of understand the thought processes that people have to go through, or people do go through as a result of PTSD. So this is negative alterations in cognitions and mood. So so it's kind of basic stuff like not being able to recall key features of what happened, but this one's mostly about negative beliefs that develop and negative expectations about oneself, one's role in the trauma, other people's role in the trauma, really negative beliefs and emotions related to the world and how the world functions, right? So it's that kind of cognitive triad about self, others, and the world. And that really comes into play here quite a bit. And then related to that, obviously, lots of negative trauma-related emotions, which is not surprising. Fear, horror, lots of guilt, lots of shame, depending on the trauma, that kind of a thing. And then there's this sort of depressive piece too, where the person sort of has a constricted affect, like they can really only experience negative emotions or they're pretty numb. Difficulty or having a reduced experience of positive emotions, and then diminished interest in things that they were interested in prior to the trauma, whether those are actually trauma content related or not. It's sort of a general thing. And then feeling kind of alienated and isolated from others. So those are the main PTSD criteria for from the DSM. But then there's other common symptoms too that we see quite a bit. And again, be thinking about your clients who you see when you see this list here. Now, depression and PTSD go hand in hand. There's been numerous research that verifies that. Guilt is a really big piece of this. A lot of combat veterans feel guilt, kind of survivor guilt. There's also guilt that is often very prominent in adults who, as children, experience sexual abuse or physical abuse. So guilt is a prominent a prominent symptom of PTSD. Also, people who had an unexpected death of a loved one, like a child dying. I was just consulting on a case where the client's child had overdosed on opioids in her home. And so that was a major trauma that we were working with her with, and her primary feeling, not surprisingly, was guilt. So a lot of work to do around that. And then all these other things. And then certainly if we're thinking about people with psychosis, for example, hallucinations and mild delusions as well, paranoia. But what we also know is that even people who don't have psychosis, who do have PTSD, people in the general population, so to speak, people who don't have other serious mental illness kinds of diagnoses or conditions, they can hear voices and have paranoia as well. So these are some of the things that happen alongside of PTSD. And, you know, as we were talking about the different kinds of beliefs that people develop as a result of a trauma, this is a list. It is by no means comprehensive, but these are kind of the big ones. These are the kinds of trauma-related beliefs that people have. And what's interesting about this is that it's not just specific to the kind of trauma that you've experienced or sort of your demographic characteristics or your gender or your background or your socioeconomic status or anything like that. You could have a 70-year-old Caucasian male combat veteran who holds some of these beliefs or all of them, and another person across the country, for example, geographically, who might also hold these beliefs is a 17-year-old African-American teenage girl who's been raped. And so these are very universal beliefs that unfortunately people develop and hold on to as related to trauma. Okay, we stop there for 1 second. How are we doing so far with this little introduction? Does anyone have questions or anything before we go forward? Okay, so we did a little bit of defining of the problem, what all the criteria is and what we're talking about here. Now let me give you a little bit of data, the research about the rates of trauma and PTSD in people who have serious mental illness. Let's take a look at this. This is a study done by a colleague of mine a while ago about the rates of trauma in people who have SMI. And there are 275 people here. And you can see here, just to kind of give you a painted picture of this, to help you decipher the chart a little bit. So this is divided up into women and men. It's divided up into traumas that occurred when the person was a child versus when the person was an adult. And it marks out here kind of the big three: sexual assault, physical assault, and witnessing an assault or death. And what you can see here is there are large proportions of men and women who experience all of these different traumas in childhood and adulthood. And what we're looking at is people experiencing trauma in a very high level way, meaning that there's a high percentage of people who are in the study who experience trauma. Close to, in some cases, if we're looking at women in adulthood with sexual assault, close to 70% had experienced that trauma. And some of this might be overlapping as well. So we're seeing very high rates of trauma in people who also have serious mental illness. Even when, we break it down by childhood, adulthood, men, women, it's all quite high, and higher than what the general population experiences trauma-wise. Let's take a look at PTSD. So we're just talking about traumatic events. And remember, as I said before, just because someone has experienced a traumatic event does not mean they definitely always go on to develop PTSD. At least that's generally the case in the general population, people who don't have SMI. But let's look here at people who do have SMI. And so this is like a whole grouping of studies that have been done over the years, big studies, smaller studies, all kinds of things that demonstrate the rates of PTSD in people who have SMI. And you'll see here again, very high rates, somewhere between 20 and 50% of people with SMI meet criteria for PTSD, which is really telling and really important. So if you're thinking of your own caseloads here and how many people are on your caseload, and I know it's quite a bit for many of you, think about the fact that probably close to half of those clients might have PTSD. You may know that about some of them, but you probably don't know that about a lot of them. And I'm going to talk a little bit more about that as a challenge as well. So there's a lot of research here that's been done over the years. And, I think what it's really telling us, as this person astutely says at this meeting, the latest research shows that we really should be doing something with all of this research. And that's really true. We can do study after study verifying and validating these rates. And we do keep doing it, and they keep coming up high. But then what, right? What's to do about it, and how do we understand that, and how do we put that into action? And that's why I do the work that I do and why I'm here today. Okay, so now let's understand and acknowledge the problem a little bit. So we've defined it, and we've looked at the data related to the problem. And so let's take a look at what it looks like, what trauma and PTSD can actually look like in somebody who does have serious mental illness. Let me stop there for a second, though, and see if any questions have come up. Okay, well, let's go forward then. Let me just do a little test here. I just want to make sure that I'm able to see if Sam's trying to contact me or if anyone does have questions. And that would come up in chat, right? When I don't see anything next to chat, so I think I'm good. Okay, all right. Let's go forward here a little bit. Okay, so if we're talking about people who have serious mental illness, who have a history of trauma, what ends up happening in terms of that person's current life, regardless of whether their traumatic event was back in childhood or 2 years ago? What do we know? Well, we know a lot, and it's not pretty, not a good picture. Basically, what we know is that if someone has serious mental illness and they have a history of trauma, their symptoms will be more severe, meaning they're symptoms of their serious mental illness condition. So, for example, if someone has bipolar disorder and has trauma, their bipolar symptoms, hypomania or mania, will be worse. Someone with depression who has trauma will have more severe depressive symptoms that take longer to remit. Someone with schizophrenia who has trauma, a history of trauma, will have more severe and intractable voices and paranoia and delusions and more conviction in them, meaning that they're beliefs around them are a little bit more rigid or dug in than someone who doesn't. The same with substance abuse and substance use. We know already that people who have these kinds of diagnoses, bipolar, schizophrenia, etc., have a higher rate of substance use than people who don't. But what we know now too is that if there's trauma on top of that, then that substance use is that much worse. Same with medical problems, right? Same with higher service utilization and hospitalization. So what this means is not the good kind of service utilization where someone is actively participating in their treatment and coming into all their appointments and not no-showing and you know, participating fully in their recovery. It's kind of the bad kind of service utilization where there's more ER visits, more acute care visits, more inpatient hospitalizations when someone has trauma history alongside of their mental health condition. What we also see is increased rates of HIV, which is not surprising when we also know that people who have SMI, who have a history of trauma, tend to engage in more risky behaviors, sexual, sharing needles, other drug use, all kinds of things. That occurs at a higher rate as well. And then, you know, if we're thinking about what that means, taking all that together, people who have more severe, say, psychotic symptoms, who are abusing or using substances more frequently and at higher rates, who are engaging in risky behaviors, well, that makes people vulnerable in many ways to being re-victimized. So meaning having an additional trauma occur in the course of their adult life because they have had a trauma previously and that's intermingling with their SMI condition. The other thing that's getting more and more attention these days, which is really important, I'm so glad about it, is the idea of traumatization via the mental health system, and how if someone has experienced a trauma in their childhood or earlier in life, and then they have a negative or traumatic experience in the mental health system, that can really create a PTSD reaction. So the kinds of things I'm talking about are, you know, a young adult being picked up at their dorm room by the police and dragged out because of psychosis or some kind of acting out behavior that's related to the onset of mental illness, being locked up in prison, being injected with medications, put in restraints, all the sort of horrible things that can go on in an inpatient unit, serves to re-traumatize clients a lot, which clearly doesn't make things better. And finally, what we see is an increased frequency of PTSD in people who have serious mental illness. So I said before, trauma doesn't always lead to PTSD. Just because someone has a trauma doesn't mean they automatically have PTSD. And that's still true in this case, but not as true, unfortunately. What we see is, you know, upwards of 35% or even higher of people who have a trauma who have SMI do go on to develop PTSD. As opposed to a much smaller percentage in the general population of people who don't have an SMI. So some tough stuff here, but maybe not surprising. You know, you all work with clients who have these kinds of problems and challenges, and so you know, you've probably seen this. Sometimes it's helpful to see it all kind of laid out on a page like this to really get the clear picture about what the research says truly are all the negative consequences or correlates of having trauma when you also have a serious mental illness. And this is another way to look at it. A colleague of mine, Kim Muser, developed this, and there's a lot of arrows pointing in a lot of directions, so I like to kind of work it out with someone. So think of a client of yours as we kind of go through this. And starting on the left side here, you know, as I said, if someone has a trauma history and they have SMI, they have an increased likelihood of developing PTSD. Right? So that leads us to this arrow. What we also talked about is if someone has PTSD, they have an increased likelihood of being re-traumatized, right? Either because they're homeless in a vulnerable position, or they're engaging in more risky behaviors, or they're interacting in unhealthy relationships with people who are going to harm them, or a variety of different things, right? What we also know, if we come up here to the top, that substance use interacts with all of this. So we know that people who have trauma, a trauma history, and SMI tend to have higher rates of substance use, right? We just talked about that on the previous slide. But it also has this other directional effect, in that if people are abusing substances at a high rate and are frequently under the influence, they again have a higher likelihood of being re-victimized and experiencing another trauma, which increases their PTSD. So you've got a little unfortunate loop here. And then all of this to say at the top here leads to symptom severity. So we talked about that. So if you've got SMI and trauma, and or you're using substances, or even if you're not, frankly, and you're being re-victimized, or even if you're not, frankly, your symptoms of both your PTSD and your sort of original condition, bipolar disorder, depression, whatever it is, are going to be worse. And your functioning, your sort of overall and social functioning is going to be worse as well. So that's the kind of the top part here. And then thinking about how that leads to illness management services, well, technically, you know, if someone has severe symptoms, they're going to have to use illness management services, mental health services is another way to put that, more frequently and use them well. But what we know is that that doesn't always happen, which is what I was mentioning before. So let's go back to this green PTSD box here. See the arrow pointing down that says working alliance. Working alliance means basically the working relationship that a client has with his or her treatment team or primary therapist or prescriber, whomever, you know, all of those people on their treatment team. And what we know about PTSD and people who have SMI is that they have a weaker or worse working alliance with their treatment team or members of their treatment team. And if you think about it, it makes sense, right? These are the clients who are distrustful because they have PTSD and they have these cognitions. People can't be trusted, right? Also, they might have an exacerbation of psychotic symptoms if they have PTSD. So that paranoia comes into play, which reduces the working alliance that you would have, that a person would have with their treatment team. In addition, it happens in other ways. So, you know, these are your clients who no-show a lot, who say they're going to participate in something, then don't end up coming in, who drop off the face of the earth for 3 months and you can't find them, and then they kind of find their way back into treatment sometimes, right? And a lot of that is PTSD related. It's avoidance behavior. It's being triggered by different kinds of trauma-related stimuli, or having trouble coping with stress properly, and the substance use, and the severity of the symptoms, and just kind of the distrust of the mental health system, which is sometimes valid, sometimes not. But that really compromises working alliance, right? And if you've got a client who is not coming in regularly, is not using services well, is not engaged, then their use of these illness management services is going to decrease, right? Which then leads to even more symptom severity and poor functioning, and so on and so on and so on. So this is basically the chart, the table of all the bad stuff. But hopefully conceptualizing it this way makes sense. And if you're thinking about specific clients you have, you can really get a feel for what that looks like, and think about how that might manifest in a couple of your clients. Specifically, some of your clients who you might have felt challenged by in terms of their, what is perceived as their commitment to their recovery, or their commitment to coming in and engaging with you in the ways that you're advising them to, or you're recommending. So let's let that percolate for a second. Questions or thoughts about that anyone would like to share about a client that comes to mind? We have a minute or two to mull that over. Oh, here's something. Okay, let me take a question here. So are there correlations between different kinds of substances to different kinds of symptoms? As far as I know, there aren't. It's just kind of like the general idea of being under the influence, and how that impacts a person's functioning and ability to sort of cope with their PTSD, and the reverse too, that, you know, someone who has PTSD would be more prone to be using substances as a way to try to help them sleep or get their mind off of what they're going through or reduce feeling numb. There's a lot of different reasons, right? It's kind of that self-medication idea. And it really isn't substance specific. It's more kind of like, whatever that person's drug of choice would be. Good question. Thank you. There's another question here. Trauma contributes to the possibility of experiencing PTSD, but does trauma contribute to the likelihood of someone experiencing SMI? That's a very good question. I'm actually going to address that on the very next slide. So the person that wrote this in is psychic in some way, or they're just thinking about this in a nice way that I'm glad to see. Okay. So let me move on to that, and then we'll answer that question. We're going to actually, it's a couple slides away, but we're getting to it. Okay. And if I don't mention it in a way that answers your question, please, write back in. Okay. Okay. So, excuse me. I think this is a slide that can be very valuable because one of the things that I want to happen, which is why I do these kinds of presentations and share this information, is because I want people to start to look at some of their clients through the lens of trauma and PTSD and the consequences of that. And some people are doing that already, and some people are doing that with all their clients, but some people are doing it with maybe only some of their clients, the obvious ones, the ones where you know for some reason that they have PTSD. And some people might not be doing it that much because there's, we have hard jobs, difficult, challenging jobs, and there's a lot of other things to be thinking about. So, but this is a way to kind of really kind of understand and think about your clients from this perspective. So here are some themes that I've collected over the years from my clinical experience and from, the research and so forth, related to common trauma, common behaviors or themes or patterns that are often misinterpreted as something else, but are really probably related to trauma or PTSD. And this is by no means an exhaustive list. Certainly there's other things that could go on this list, very specific other kinds of behaviors that you all might have experienced with your clients. And maybe in the moment you thought, gosh, I really think this is because of PTSD or avoidance, but maybe it didn't. Maybe it kind of slipped your mind, or you thought it was something else, or you just reacted to it as we do as humans and kind of felt, a little offended or nervous or defensive or scared and didn't really, have the opportunity to understand what it was about. But now that you see this now, maybe that's an opportunity to think a little bit about, gosh, maybe when I interacted with, Susan 2 years ago, and she told me about all those violent or sexual thoughts she was having, it's now clearer to me that perhaps those were related to what she experienced as a child, because even though she didn't have a diagnosis of PTSD, she hadn't really been diagnosed properly or hadn't been screened, and I didn't really know whether she had trauma or PTSD, and maybe it was related. That kind of thought process to just sort of explore that a little bit within yourself. So here's some things here, all related to violent and sexual thoughts. Again, that working alliance with therapists, missing appointments, paranoia, when your client seems sort of defensive or combative in session, those kinds of kind of interpersonal therapy things. And then just kind of the person's way of communicating. Tangentiality, acting out of memories could seem like psychosis, understandably, or mania even, but really it's just being triggered by the PTSD and reacting to it. And then, this third one from the bottom, recapitulation of unhealthy childhood relationships and present adult relationships. Well, that one's a little bit of a no-brainer, I have to say. So you can see if someone had a unhealthy relationship growing up with a parent, and, by unhealthy, I mean traumatic, and if they were physically or sexually abused, you could see how that would manifest in people's current relationships, obviously, or their own relationships to their children, with their children, which brings me to this last one, which I think sometimes is something that doesn't quite get pulled to the forefront maybe as much as it should, that parents or adults who are parents who have gone through their own traumas themselves and have untreated or unresolved PTSD end up being triggered by their own child, either because the child is exhibiting some kind of unhealthy behavior that reminds them or triggers them about their own traumatic experiences, or the child has undergone a trauma as well and is having their own trauma reactions, which also kind of triggers the parents. So that's an important thing. And then, of course, drug or alcohol use. Oops. Okay, and again, I bring the slide back up because these are the kinds of beliefs on this slide that trigger these kinds of behaviors, right? And sometimes this is sort of underground in that it's not obvious to the client even or the clinician that this is causing this. Does that make sense to people? Okay, now on to the question about, can trauma or PTSD trigger an SMI? What we know here is that traumatic experiences, if we're talking about psychosis, this is kind of the most robust finding with psychosis and schizophrenia. So there's been studies on and on and on about this. So this is the most prominent finding related to SMI. Traumatic experiences are a really robust and important predictor of psychotic symptoms. What that means is that experiences that a person had in childhood, traumatic experiences, defined by the DSM trauma, traumatic experiences in childhood and adolescence significantly increase the risk for development of psychosis and schizophrenia later on. And so, yes, really, that if you have had trauma and PTSD, you have a much higher likelihood of developing psychosis and schizophrenia. And that's unfortunate, obviously, but that's what we're understanding it as these days. The other thing, I want to talk a little bit more about psychosis and schizophrenia and trauma because there's really important links here that we've learned a lot about over the years. Think about clients who you currently have or who you have had in the past who have psychosis, who have schizophrenia or schizoaffective, but who have some kind of psychosis. And think about the content of those psychotic symptoms. So if they heard voices, what did the voices say to them? What kind of voice was it? Was the voice, a man or someone who was in their life previously? What were their delusions about? Maybe they seemed like they didn't make sense at all, but maybe they did. Maybe they were very sort of systematized. What was the content of their delusions? What was the content of their paranoia? What were they paranoid about? And oftentimes, I would say 9 times out of 10, but don't quote me on that. That's a clinical observation. I would say 9 times out of 10, the content of the person's psychosis can be linked in some way to what their previous traumatic experiences were. Sometimes it's like on the nose, like, someone hears the voice of the uncle who perpetrated their sexual abuse 35 years ago. Sometimes it feels a little bit more kind of abstract, but it's there. You can see the link, you can understand the link. And that's an important thing to really start to formulate as you think about your clients, right? And the other thing, and I mentioned this before, to kind of help people understand the link between psychotic symptoms and PTSD in general, is that even in people who don't have a SMI or other diagnosed mental health condition besides PTSD, they can often also have hallucinations, delusions, or what we would call bizarre behavior. And that's something of note because I think that helps us understand a little bit that psychosis really does occur in a continuum, and there really is a link between trauma, PTSD, and psychotic symptoms. Okay. Oops. Sorry, I'm having a little trouble with my clicker here. Okay. So now we've learned some things about how this is all linked up together and what it means. And the ways in which having PTSD, being exposed to trauma, and having a serious mental illness can make a big difference for people in a negative way. Sorry, I'm having a little bit of scrolling trouble. Please bear with me. Okay. So now we know a little bit more about what this looks like in our clients, right? And again, some of this might not seem like a surprise at all. You might be right on the pulse of this, which is fantastic. I found that even in those cases when you have a lot of clients who meet this criteria and who look like this, it's still sometimes a little surprising, right? Like certain people, just to kind of see it on paper, you guys work really hard and you see a lot of clients and you have a lot of things to balance, but to be able to dedicate some time to thinking about it in this way, I think can be really helpful. So I hope that's what everyone is experiencing right at this moment. So here's the thing, right? Trauma and PTSD are major issues for people with SMI, major problems. However, both trauma history and diagnosis of PTSD is highly underdiagnosed in mental health clinics, despite what the prevalence data tells us. This is not happening routinely in mental health clinics. So a very small percentage of clients have PTSD diagnoses in their clinical medical records. That's just what we've learned over time. So for example, this one study, the CUSAC study, they, I forget what the number of people they screened was. It was in the hundreds. Out of the people they screened who had a PTSD diagnosis, who met criteria for PTSD, which was lining up with what we know about PTSD, so like 40% of people, only 3% of those who met their screening criteria actually had it recorded previously in their medical record that, yes, this person has PTSD. Now, why is that, right? There's a lot of reasons. I think there's this idea that it gets misdiagnosed, the psychosis gets top billing, so to speak, the PTSD symptoms get buried in there. It's also about like kind of knowing what the right questions to ask and how to ask them, right? And this is not necessarily a criticism of the United States. This happens a lot of places. So I did some work in Spain over the past couple years, and we did a really big screening study because I was interested to know, is this going on in Spain too, where there's these public mental health clinics, just like in the US, that are dedicated to serving clients who have trauma and PTSD, and how are they detecting, who are dedicated to serving clients who have SMI, how are they detecting trauma and PTSD? Are they doing it? What's it looking like? How's it happening? So we did this big study and basically came up with the same rates that we have that my colleagues and I have in the United States, and some of our other colleagues have found too. So we screened 323 people who were being seen at this mental health clinic in Madrid. And 84.2% of them reported that they had had at least one traumatic event. Many people had many more than that. And that's kind of the norm in this population anyway. It's that you don't just have one traumatic event, you have, 3 or 5 or 7 even. Thinking about your own clients, keeping that in mind too. Anyway, so 84% had reported at least one traumatic event. And then 124 of those 272, so 38, almost 39% of those clients met criteria for PTSD. So we had about almost 40% of the clients there meeting criteria for PTSD, and 0 clients, when we looked through their medical records, had a recorded medical record diagnosis of PTSD. So not criticizing the U.S., criticizing the whole world, I guess. That this is a problem, and that we're really missing the boat here. And again, there are reasons why this happens. And as I said, just kind of not having the infrastructure in place to do enough assessments because of limited resources and so forth, kind of having other symptoms look more prominent or kind of shadow over other things. But really, I think a big piece of it, we're going to talk about this in a few minutes, is this idea about it not sort of having the proper mechanism, tools, attitude, or willingness to approach this. And again, not because, our community mental health clinics or our staff or leaders there are bad people. They're wonderful people, right? We're all in the business to help. But just having the sense that there's not, to do this would make things worse, right? And that's one of the things that I and my colleagues who do this work really want to help people see a little bit differently. As you can see from the information I just presented this morning so far, people are already doing pretty badly, right? If you've got PTSD and it's undiagnosed, or even if it is diagnosed and it's untreated, you're not doing so well, right? All of the ways in which your life can be upended are happening. More severe symptoms, hospitalization, substance use, risky behaviors, increased medical problems, all these kinds of things. So it's not like we're saving people from anything by not addressing or approaching trauma, right? So that's my little soapbox just for now. I'll come back to that. But let's talk a little bit more from a clinical perspective about why is this bad? Why is it bad to not diagnose PTSD or have it in the medical record or talk to clients about it? There's really important clinical implications here. First of all, if you don't know that someone has PTSD, you don't really know. You can't treat them, right? You can't offer them a PTSD treatment, and then they're continuing to have distress kind of needlessly. That's sort of the most obvious thing, right? And then the other thing I think that happens, and this happens a lot, is misinterpreting PTSD symptoms, thinking that they are a manifestation of a different condition. So for example, hallucinations, as we talked about, occur in people who have PTSD. It's not that uncommon. And hallucinations can be mistaken for schizophrenia if we don't know that the person has PTSD or they haven't been screened properly. And hyperarousal symptoms, that jumpiness, that fastness, that exaggerated startle response, that irritability, all that we talked about can look like what? Mania, right? Hypomania. And so we're in a situation where if we're not looking for PTSD and it's not being evaluated properly and diagnosed properly, then we've got people who are being diagnosed with something else and therefore treated for that thing with interventions, with treatment plans reflecting interventions for a disorder that they may not have, with medications that they may not need or might not be the right medications for them if they don't actually have those specific problems. So that's another thing, that misinterpretation is really important. And, you know, as we've talked about already, the presence of PTSD can hinder the therapeutic alliance. So if you don't know that your client has PTSD and your client hasn't been told they had PTSD, and you guys are kind of at odds, or you're not working well together, and the client doesn't trust you, or the client's not showing up, or whatever, that obviously hinders the therapeutic alliance. So those are some reasons why it's bad, basically, to be in a position where you're not, or the mental health system isn't addressing or screening for or diagnosing trauma and PTSD in an effective way. And also where clients aren't being conceptualized through a trauma lens when we know so many of them have had a traumatic experience. So that's what I'm hoping, you know, to impart to you a bit today, is this idea about how prevalent and problematic it is, how much it can impact a client if they have these kinds of symptoms and problems that aren't being addressed, and at a systematic level, how it can, you know, really be damaging to mental health systems, mental health clinicians, mental health clientele that you're serving at your agencies. Okay. Okay, so there's a question here. Has there been work done around how cultural differerences between therapist and client contextualize and or increase the misunderstanding of trauma symptoms in this population? That's a really great question. There's certainly, and this is coming from Brian, so there's certainly been research about misdiagnosis because of cultural manifestations of symptoms, right? In terms of, for example, I believe the finding is that African American men at least in the past, have sometimes been diagnosed at higher rates inaccurately with schizophrenia or psychosis than Caucasian men. And that's all sometimes related to the interaction between the therapist and the client, right, in terms of cultural or ethnic differences. I don't know of a study or a set of findings that have indicated if that's related to trauma or the diagnosis of PTSD in this population. That's a good question. I don't know the answer to that off the top of my head, though. Okay. So there's another question coming in here. How does treatment for PTSD differ from SMI? I think the question is, how does treatment for PTSD differ from treatment for SMI? If the symptoms are the same on some level, how does one get an actually accurate diagnosis and therefore the most effective treatment? So Kendra, I think you asked a good question before, right? And I told you before that you were psychic because we were going to come up on this, and we did when we talked about the link between psychosis and trauma. And so I'm going to tell you again that this is actually on our agenda to talk about a little bit later in the webinar. I'm going to talk about some different treatments for PTSD and how you would approach PTSD treatment-wise in this population, and also how you would accurately diagnose it. So hang on, if you would, and I will come back to that. Okay, thank you. Okay, so let me just go back a little bit to where I was here. So this is one of the reasons why it's bad. And here's some other kinds of consequences that I think are also worth thinking about and understanding. And I think this top one, in some ways, is the most important of them all. So there's been studies done of mental health services users, consumers, our clients basically, who report being upset about not being asked about abuse, about not being asked about trauma history, about not being screened for this, or having PTSD be part of the diagnostic evaluation that gets done. And that's really major, I think, because what these clients are saying is, this was such a significant part of my life, you know, whether it was the abuse or the sudden death of my mother, or the neglect I suffered, or the assault I suffered, or the combat I was in, or the major accident, or whatever it was, such a major part of my life that I can't shake. And yet it's not being addressed in the place that I go to seek mental health treatment. And that's a big one. You know, I think I can stand here and kind of say all the reasons why it's bad to not address trauma or PTSD or think about it in this way. But really, you know, when you've got the clientele themselves saying, you know, no one ever asked me about this. I can't believe it. You know, it's such a major part of my life. That's really important. And, you know, these are just some general things that we know too. Inhibiting or holding back our thoughts, our feelings, our behaviors are associated with toxic stress, traumatic or not, right? And certainly you can imagine that when it is trauma related, that's even worse. And, you know, there's a lot of research about childhood sexual abuse, and we talked about that in terms of development of psychosis, but there's a lot around that in terms of later suicidality as a predictor. And so, you know, there's been some strong statements here that people have made, such as any attempt to address suicide reduction that does not include assessment of childhood sexual trauma will fail. I think that's probably true. And, you know, I think these are really important facets of people's experience that we don't want to separate so much from their current lives, right? We have to kind of understand it as the big picture. And really, I think, you know, by not addressing it, this is sort of the message that we're sending. And this poor elephant who's in psychoanalysis saying, sometimes even if I stand in the middle of the room, no one acknowledges me. And that's over the years kind of, unfortunately, and not through any malicious intent, but unfortunately is kind of what's been happening in terms of people who have serious mental illness and SMI. Okay. Oops. All right. So let's kind of summarize this for a second here, but actually, let me see. I think there's another question. getting a couple of things here. Sorry, if I don't answer every question, I apologize. It's kind of I'm trying to sift through it and also kind of keep us to time. So let me see what I can do here. So one question is, I joined in late, so you may have addressed this, but in your research, have you found that SMI and symptoms people can experience from that, like voices, persecutory voices, lead to PTSD in our clients who do not previously have a history of trauma or PTSD in their past? Okay, so I think I'm understanding this, which is, the question is, let's say someone does not have a trauma history, but they do have schizophrenia or they do have psychosis, right? And they're having persecutory voices that are highly distressing. Does that experience cause PTSD, right? I think that's what the question is. And actually, correct. Okay, good. I'm getting some validation that I understood the question correctly. Okay, good. Interestingly, there has been a bit of research going on, and some colleagues of mine actually did this study, Wei-Li Liu and Kim Muser. It was a very interesting study, and have found that the experience of psychosis in itself can cause a PTSD reaction, even in people who don't have that childhood history of trauma or PTSD. So yes, because the person believes these beliefs so much or hears these voices so much that it can create sort of a trauma or PTSD reaction. Okay, good. And then there's more of an observation or comment here, but a good one, so I'm going to read it if that's okay. This person says, my observation is that a diagnosis of PTSD offers more hope to the client. It can increase the client's sense of self-efficacy in the healing process, as opposed to any SMI diagnosis that seems more abstract to the client. Yeah, that's a really good point. Did everyone hear that? Well, I think you all can see it too. That's a really good point. And that is one of the things that we teach, or that I teach, when I'm teaching people about screening and why it's important, and teaching people about why doing PTSD interventions that are specific or specialized for the SMI population is important, because one of the objectives of both of those things, screening and also doing specific interventions for people with SMI and PTSD, is to instill hope. Because what you will find sometimes is, because of everything I just talked about, where this is kind of swept under the rug, or is the elephant in the room, however you want to say it, or, people, mental health agencies and clinicians feel like the clients are bigger fish to fry, so they shouldn't bring this up, et cetera, et cetera. When that happens, years go by, right? And you've got clients who have been in the mental health system since they were, 17 years old, and now they're 51. And no one has ever really talked to them about trauma, or screened them for it, or discussed it with them, or told them what PTSD is and what the symptoms are and all of that. And then when it finally happens, if and when it finally happens and it's done in the proper way, and you provide screening and education to the client about what they have, what this is, that it's a actual diagnosis, it's a condition for which there's a set of symptom criteria, and of which a lot is known about, it provides that sometimes the reaction that the clients give is really tremendous. I mean, the relief that they feel to go, oh my gosh, this makes so much sense. This is totally me. I've heard this, honestly, I've heard this a million times from people I've worked with in cases I've supervised. And they said, my gosh, I'm so glad that you're talking to me about this. This is totally me. This has been my whole life. All these things you're saying, yes to every symptom that you're telling me about. No one's ever talked to me about this. My whole life I've heard that I'm crazy, and that's why I act this way. That's why I can't have relationships. That's why I've been violent. That's why I can't stay away from injecting heroin. But this makes sense. Like, my whole life I've thought to myself, what is wrong with me? I should be over what happened to me now. I should be functioning. Why can't I do anything? And people have reinforced that in my life over and over again, that I'm out of my mind and out of control. And this makes so much sense. And that is really important for clients to hear and understand. And it does offer some hope, and it's incredibly validating. Again, when done properly. It's all about being done properly. And I'm going to talk about doing it properly in a minute here. Okay, let me just do a little bit of a summary, and then I think we're probably ready for a break. So just to kind of pull together some of what I've talked about so far. so that you can think about it in terms of, you know, your own work over the years as clinicians, some of the clients you've worked with, clients you're currently working with, the way that your mental health agency functions or works or brings in new clients or whatever. One, trauma and other adverse events in childhood increase the risk of developing co-occurring psychiatric conditions. Primarily, the thing we know the most about is psychosis and schizophrenia, right? Incredibly high rates of trauma and PTSD in the SMI population, right? We're talking close to 50% in some cases compared to much lower rates of PTSD in the general population. Tremendously different, right? Multiple traumas are common. They're the norm. On average, it's not just someone, you know, who's 45 and has bipolar disorder and has been in the mental health system for 25 years. It's not that they've just had one trauma happen to them. They've had multiple traumas over the course of their lifetime, in part related to that chart I showed you, the way that everything kind of interacts and makes things worse, basically. So on average, 7.43 traumatic events per person. That is a lot. We're going to talk about a case in a minute that I supervised that kind of illustrates that a little bit. And there's that possibility of additional traumatization via the mental health system, the violent hospitalizations, the forced medication, et cetera. So that's kind of the re-victimization piece. And again, just to really nail this home, if you haven't gotten it already, but I think you have, the history of trauma and PTSD is associated with more severe psychiatric symptoms of the original diagnosis, higher levels of distress, worse impairment, e.g. more trouble functioning out in the world, higher levels of acute or emergency care treatment, worse physical health. I could go on, which I already did, but that's just kind of a summary. Basically, everything's worse if you have untreated trauma and PTSD as well as SMI. And then this bottom piece here, which, as I said, I think in many ways is the most important thing, that service users themselves report that their traumatic experiences and their reactions to their traumatic experiences are really important, but actually a neglected treatment priority in the places where they receive their care. So I think that's very, very important. Okay, so we've got another question here that I'll address, and then we'll probably move to a break. Does ongoing sexual or physical abuse over the years count as one traumatic event, or is each instance considered an additional event? Okay. Excuse me, again, a good question. You know, I guess, it sort of depends. Oftentimes, we will have an adult client who reports that in their childhood, they were, for example, sexually abused by a neighbor or an uncle in an ongoing way. Typically more if it's a relative, it's in an ongoing way because of just kind of access over the course of years, right? Ages, people will say ages 3 to 12 or something like that, right? That is just one instance, right? That counts as one traumatic event. It was ongoing, but it counts as one traumatic event. The same goes for physical abuse. If it was sort of different people, like, for example, there was a case where someone had been sexually abused by their uncle for a period of time and then also had a sexual abuse experience at an overnight camp perpetrated by an older camper. That's two different traumatic events, sort of. You'll learn more about this when you see the screening and how it's kind of worded. So it kind of depends. But the point, I think, the sort of take-home point of this is that when we're talking about multiple instances, the 7.3 statistic is about sexual abuse. And in my lifetime, I have experienced sexual abuse, physical abuse, a car accident, witnessed domestic violence, was stalked, had the unexpected death of a family member, and was in a violent relationship as an adult, and was part of a major flood that damaged my house. So that's 8, right? So that's the kind of thing that we're seeing, is that people are having all these different kinds of traumas across their lifespan, in large part related to that victimization and that vulnerability that comes up. Okay, so let's see where we are. Oops. Okay, perfect. Okay, so we've talked all about the problem. Like anything, you know, when you're working with trauma or PTSD as a clinician, you have to take a break sometimes and do some self-care. So let's take a little bit of a breather from the problem. Let's do a 15-minute break. You know, we'll all go our separate ways for about 15 minutes, then come back. So please come back at 10:30, because, you know, there is additional information that I want to talk about. We're going to do the case when we get back, a little bit about our own cognitions related to trauma, and also I'm going to talk about some treatment interventions for this population, and the screening piece. So all important stuff, and then plus all of our ending things. So thank you for being great participants for our first half, and we will reconvene in 15 minutes at 10:30. Okay. Oh, I think we're back.
And we
Okay.
have one question come in over the break from Stephen Peck. Could childhood abandonment by parent be considered trauma?
Okay, yeah, I see a couple of things that I haven't gotten to address yet, including that new one, and then there was one back up at the top that I didn't get to. Just trying to keep in mind some of what I need to cover. Stephen, I'm going to try to address that when we talk about the screening and what the items on the screening look like, if that's okay with you. And then if we want to talk more about it, then if the answer doesn't feel clear, we can talk more about it then. Is that okay? If you're on? Okay. Okay, I got it. Okie dokie. Great. All right. Well, let's pick up back where we were, and I'm glad to see that some of this is percolating, because I'm getting a few questions in here that have popped up. And what I'd like to do, if it's okay with everyone, is forge ahead a little bit, because I think some of what I talk about next is going to answer some of the questions that were asked. And I also do want to make sure I get to some of this practical stuff, like talking about the case and talking about treatment interventions and the screening. So I'm just going to forge ahead, if that's okay with everyone. And then we'll pick up where we left off with questions towards the end. Okay, so just to bring us all back in post-break to what we were talking about here. Here are some kind of the high points of what we were just discussing. And, you know, I think some of the questions are being generated from your experiences with your own cases, which is great. There was actually one that I did realize I skipped that I do want to address briefly, that I think was Elizabeth, who asked, oops, I lost my chat box here. Elizabeth asked something about, yes, is there a link between childhood sexual trauma and development of pedophilia? That's a great question. Is there a higher likelihood that a person with pedophilia would experience sexual trauma in childhood? The short answer is yes, that does increase the likelihood. There's been not as much research around this as you might have thought that there would be, or that it would be natural that there would be, or that there should be. But there have been several studies that have indicated that yes, people who have a diagnosis of pedophilia do tend to have their own past experiences of childhood sexual abuse, by and large. What is not totally consistent is like the percentage of time that happens. And so there's been a lot of mixed reviews in that, but you're thinking along the right lines that yes, that would make sense, wouldn't it? Okay, all right, let me jump ahead, or jump forward, not ahead really, to where we are. Okay. Now let's bring the problem to life a little bit. And I think you guys have been bringing it to life in your own minds with your own clients, but I'd like to talk about a particular case who I had known a great deal about. And this is Lorna, not her real name. And I'm just going to give you some background. And as I'm talking about this, think about your own clients and, you know, what are the similarities between your clients and Lorna? What might some of the differences be in terms of what she's been through and what it looks like? So this is a Caucasian female, age 47, never married, although had had a series of fairly unhealthy heterosexual relationships, and has one estranged adult child who she doesn't have contact with. She has a diagnosis of schizoaffective disorder, a medical record diagnosis in her chart, a history of drug and alcohol dependence on and off over the years, but sober for the past 2 years via a variety of supports, including NA and AA. Has been in and out of the mental health system since age 25. So kind of like a typical, not that any person is typical, but kind of what we see a lot with people who have struggled from early on with trauma or other kinds of symptoms, with substance abuse, who find themselves at an early age with their first experience into the mental health system, and then kind of that revolving door piece that happens over time as well. So in and out of the mental health system since age 25. This person was in New Jersey and was living in supported housing, which is, I know, something similar to what you all have in Washington, although you might call it something different. Basically living in an apartment complex with other people who are also part of the mental health system in that same agency. And the apartment is kind of managed or supported by staff who are employees of that mental health agency. So there's someone kind of on call and who is often staying at the site. Okay, you might call it something different there. Okay, so the client was really to a point where she was unable to work for years it had been, despite some earlier aspirations. She had to go into nursing, and she was unable to live independently currently, and I'll talk more about why that was, and what some of the symptoms that she was experiencing were in a minute. As far as her relationship with the mental health system or her treatment team, periods of really sporadic attendance for clinic appointments. You know, she'd show up and she'd be there for an appointment or two and, you know, stop into a group and participate sort of, and then be gone for 2 or 3 weeks. Sometimes she'd call and cancel. Sometimes she just wouldn't show up, that kind of a thing. But she did have an individual sort of primary clinician who she was technically connected to through her involvement at the mental health agency. Okay, so her trauma history is pretty dense and multi-layered. So in childhood, she basically suffered from a history of combined neglect, physical abuse, and sexual abuse by her parents and sort of friends and associates of her parents. Basically, her parents had their own mental health problems themselves, probably undiagnosed. They were involved in heavy drug use and had 2 kids and were involved in some drug dealing as well. And you know, as a result of their own heavy drug use, were basically unable to really provide a safe and reasonable home situation for Lorna or her brother. She had an older brother. And as a result, their home life was totally chaotic, you know, unhygienic housing and people coming in and out of the house at all hours of the night, her parents taking off here and there, kind of what you would imagine, all the bad things that you would imagine having, being a part of this environment. So Lorna was frequently in very unsafe situations, physically, sexually, all kinds of people and exposure to drugs and needles and all kinds of things, with frequency across, you know, the span of her childhood for a period of time. So her index trauma, and I'll talk more about technically what an index trauma is as it pertains to screening, because this was her index trauma at screening, was ongoing severe childhood physical and sexual abuse. So it's kind of, you'll see on the screening questionnaire, sort of two traumas that were related to each other because they sort of happened in the same time frame with the same perpetrators. I think that answers a little bit what someone's question was before, related to sort of how to count out individual traumatic events. So the index trauma we term, and I will talk more about this in a second, is kind of out of all the traumatic experiences that the person has had in their lifetime, which one they feel from their perspective is the most distressing. The one that is currently most distressing to them in their present life, the one that's kind of getting to them the most, the one that still bothers them the most. And it's the client's perspective on that. They can choose whichever one they see fit, and I'll talk more about that in a second. Now, interestingly, this client had some psychosis on board. She had a diagnosis of schizoaffective disorder. She had some communication impairments related to that, and some delusional ideas and voices. I'll talk more about her psychotic symptoms. So when she was asked to write down or describe what the trauma was that she had experienced, her words were, "I was held captive in a drug ring from age 3 to 17 that my parents were involved in." And so, you know, that is sort of true, right? In that it lines up with, you know, some of the ways in which drugs were really sort of paramount in her experience, and the consequences of her parents' major drug use and a little bit of their dealing. And so, you know, it lines up with that. As you can see, though, and this is what we get sometimes with people who experience psychosis, is what we call like a delusional elaboration. So it really was that she was sort of describing it as a drug ring, like a real, like a cartel drug ring situation, kind of more formalized and elaborate than it actually was. However, these were her words, and we go with that, okay, in a lot of these situations to kind of meet the client where they're at, provided that, you know, we can understand what happened, and that it sort of qualifies for a traumatic event, which it certainly does, knowing what we know. And I'll talk about what the TLEQ and the PCL are in a second, but just by way of preview, she endorsed 9 out of the 16 traumatic experiences on the TLEQ. So again, that kind of lines up with the idea of multiple traumas being the norm for people who have SMI. So across childhood and adulthood, so she's 47, she experienced 9 out of the possible 16. You can see, you know, based on what I'm describing, that makes sense, right? And her score on the PTSD checklist, which is our screener, was a 52. So 33 is the cutoff. Cutoff meaning that if you have a 33 or higher, you likely have PTSD. Or for all intents and purposes, we say you do have PTSD. It's not a full diagnostic interview like the SCID that takes hours, but studies have shown that this measure, when compared to the SCID, lines up almost, you know, entirely. So that's sort of the shorthand that is, you know, very popular and widely used and effective. So she had a 52, and the cutoff is a 33. So pretty high PTSD. Let's talk a little bit about her symptom picture. So as I said, you know, she had schizoaffective disorder, and she has some psychotic symptoms. Delusional elaboration. So let me talk a little bit more about that, the way I was just describing it. So she would describe to the clinician and you know, other people at the mental health agency, she was kind of one of those clients who tended to talk a lot and kind of tell these sorts of stories and narratives to sort of whomever would listen, whether it was someone in the waiting room or the administrative assistant at the front desk or her therapist or someone in group. And you know, she had a lot of trouble kind of reining it in and being able to manage that, which was indicative of how much distress she was under and how much this was in the forefront of her mind and had been for years. But so she described things like drug smuggling. She described that she was forced to fly a plane as a teenager during a drug drop. She talked about having to dive underneath boats to pick up drugs that were secured to the bottom of the boats, and that she in exchange had to plant bombs underneath those boats, that she jumped out of a helicopter during different drug runs, things like that. And again, these things likely did not happen. But They are delusional elaboration of being forced to be in a variety of unsafe situations that the child should not be in, right? And this is sort of that psychotic elaboration of that. Does that make sense? I'm hoping the way I'm describing it is making sense. We see that a lot in people who have psychosis, right? So voices, also severe auditory hallucinations related to thoughts and memories about the trauma. Also heard her brother's voice. There was some question about whether her brother was also a perpetrator of sexual abuse as well. You know, he certainly went through a lot, having the parents that he had, and likely experienced similar traumas to Lorna, but that was, we sort of weren't sure if that was part of the picture or not. But anyway, she did hear his voice quite a bit. And as I said, you know, a lot of disorganization, some bizarre behavior, so to speak, tangentiality on it, challenging to kind of have a regular back and forth with her without a lot of this delusional material coming into the conversation. So maybe you can kind of picture a little bit what Lorna might present like, and maybe that lines up with some of your own clients who have psychosis. So as far as PTSD symptoms, and we gleaned this from both the PCL, which I will talk about in a second, but also, you know, from clinical observation too, avoidance of all different kinds of activities, conversation stimuli, lots of intrusive thoughts and images that she would get distracted by, including the voices that would come in and talk and bring her back to those instances of the trauma. A lot of guilt and shame that came out when we did an intervention with her. And obviously that history of problematic drug and alcohol use. Oops. So that's Lorna. And I'm not going to spoil the story too much, but I think I have to actually, because the nature of this webinar is not focused on treatment, it's focused on background and understanding of trauma and PTSD in this population. We did do a specialty treatment with her, which I'm going to describe it in a little bit, and that helped her tremendously. And it turned out that once we were able to help her deal with the PTSD and understand it better and work on some of her trauma-related cognitions, and believe me, this wasn't easy, but once we were able to do that, a lot of the psychosis and the disorganization and the tangentiality and the difficulty concentrating disintegrated. And she was so much more able to be clear in terms of clear thinking, clear communication, reduce severity and loudness of voices, reduce beliefs in terms of some of her paranoia, because what was driving a lot of the psychosis was that untreated trauma and PTSD. So that's what we learned from Lorna. And I use this as an example to kind of demonstrate what we see a lot of times in people who have psychosis or other SMI and untreated trauma and PTSD, that their lives just really aren't working so well, and there's a lot of problems associated with them. But if you can intervene and screen and understand better about the client's experience in a systematic, effective, and efficient way, and do some intervention that is designed or works well with people who have this kind of, who have PTSD, you can make a big difference in the person's life. And so as a result of the treatment, she was able to kind of drop down in her care, and she was able to start taking some classes related to getting a nursing assistant degree, a CNA degree. She was much easier, better to understand, much less distress about the voices, much better insight into what she had gone through, and much better like interpersonal relationship and relationship with her therapist. So some important stuff for sure. So maybe you all have some Lornas as well in your caseload. So important to think about the ways in which that person's trauma drives or underscores or exacerbates some of what they have experienced in their life and what they're currently experiencing. Okay, what I'd like to talk a little bit about, and I tried to, kind of thread this a little bit through our time together, is this idea of our own cognitions about approaching trauma and PTSD with our clients. And these are common kinds of thoughts, and these are things that we have been taught either in undergraduate or graduate school that the mental health system, perpetuates, that our clinic might have as an ethos. And so, we're not to sort of blame for our own cognitions about these things, but it's really helpful to just kind of honestly examine what some of our own cognitions about approaching trauma and PTSD with our clients who have SMI are. So what I'd like to do now, just for like a minute, we don't have to spend too much time on it, but is kind of do a little thinking activity, and I'll ask you guys to just type in to the chat, if you don't mind, what some of your thoughts might be. Oops. What some of your thoughts might be. And so the first thing I'm going to ask you is, what are some common beliefs that we may have about our clients' traumatic experiences? What are some common fearful thoughts that we may have about the process of screening or treating trauma or PTSD in our clients? And what are some common thoughts we may have about the impact or the outcome of screening for or treating trauma or PTSD, like sort of the consequences of it, that might be keeping us from sort of approaching this? So, I think if we can kind of think about what some of those cognitions are, that's important. So if you guys would be willing, you can send it privately to me if you don't want your name attached to it. There's a way to do that. That's perfectly fine. I just kind of want to have us be working on this as an exercise. And if for some reason you can't or don't want to type it in, just jot some of it down on a piece of paper right now for a minute or so. Some of the things are, some common things, just to kind of start us off, that I've heard and maybe myself have believed long ago before I got into this business, are things like, these clients have bigger fish to fry. They need to be dealing with their housing and their substance use and their psychotic symptoms, like where there's not time for or energy to kind of address something that happened so long ago. And that's something that we hear a lot. Okay. So, so I'm hearing a good one here that came in privately. If we initiate a conversation about their PTSD or trauma, it can re-trigger them. That's really common. It's a really common thought, and it's okay to have it, right? It's understandable, because we're having these thoughts these thoughts that we're having are coming from a place of goodness and the do no harm philosophy, right? And those are in some ways some of the hardest thoughts to kind of challenge, right? Because they're not coming from a bad place. It's not so easy to go, oh, well, that's really like a selfish, terrible thought. It's a thought out of kindness, but is it accurate, right? And based on what we know about the data that I presented today, is it helpful to go on having those kinds of thoughts? Another one that's coming into me here is, oh, I'm getting a lot now. Okay, great. They're scrolling through really fast. A fear of secondary trauma, right? I'm afraid that if I bring this up to my client, that they'll be re-traumatized. A fear of personal triggers. So I think that maybe means the same thing, that, if I bring this up, it might trigger, well, actually it could be two different things. If I bring this up to my client, they'll get re-triggered just by hearing me say it. Or maybe because of sometimes our own traumatic events that we've experienced as clinicians. If I bring this up, it's going to have an upsetting impact on me based on my own experiences, right? Oh, here's another one. This is a good one. Clients need to bring up their own experiences of PTSD trauma themselves in order for our treatment to be client-centered, right? So kind of wait, like the ball's in their court to mention it, and if they don't, or if I mention it first, then I'm not taking a client-centered approach. Yeah, and then I'm seeing re-traumatizing of the symptoms by triggers such as bringing it up. And then maybe my bias might get in the way of what the trauma is to the client. Okay, I think that's important too, kind of, this idea of like, well, I think I know what their traumatic event was, but they're saying something else, and how are my own perceptions of of what I believe, of the way I've conceptualized this client, how might those be influencing or negatively impacting, you know, our conversation about this? Yeah. Okay, getting a lot of good things here. Okay, and a lot of good questions. Right, and here's another one. I would be afraid to uncover risk for suicide or interpersonal violence, or I wouldn't know what to do in the event of uncovering those kinds of things in the moment, right? Like a legal ramification, it sounds like a duty to warn kind of thing. Yep, these are all really important. And I'm getting a lot of different ones in here, so I don't have time to address all of them because we want to get to some other stuff. But I'm so glad you guys are thinking about it and kind of acknowledging what some of these are. And now thinking about, let's kind of flip the exercise around a little bit. And now, you know, what might be, based on kind of what you've learned today, what might be some potential new, different, more accurate, based on the data sorts of thoughts to work toward adopting on this very topic. And so think about that. You can type some of these in as we go. I'm going to be presenting some more information that hopefully will help, you know, some new thoughts about this come to light. So let me just move forward here to keep us going, but feel free to keep typing in those kinds of thoughts. Okay. All right, so let me talk to you a little bit about treatment. And you know, because this is a brief webinar and an overview, I can't go too much into this, but do want to, you know, provide a little bit of information here to help you all understand what is available. And I think one of the questions that came up earlier was about, you know, if there's so much overlap between, say, schizophrenia or other SMI symptoms and problems as there are with PTSD, you know, what kinds of treatments would you do? Do you do anything different? And the short answer is yes. There are some targeted things to do. And let me just talk a little bit about, in general, what we know about treatment for PTSD, because this kind of sets the stage about what we might do with someone with SMI, okay? So in general, talking about like the general population, meaning people who don't have SMI conditions. So what we know, and this is hands down, absolutely, like hardcore research that's been done over many, many years and done beautifully, CBT is the most widely studied and replicated intervention and the most effective. So we've got exposure therapy, you guys have probably heard about that. We've got cognitive restructuring, and we've got some anxiety management strategies, all of which have empirical support. So exposure therapy being that systematic way in which we expose or help the client to relive in all of its gory horribleness the events of the trauma in order to help them habituate or become less anxious over time as they experience those memories, to show them that the memories can't hurt them and to help them therefore reduce their symptoms of PTSD. That's kind of the basic definition of exposure therapy. Cognitive restructuring is more about examining some of the beliefs that the person has that are related to the trauma, specific and general, remembering those general ones on the slides I showed you before, like undamaged goods because of what happened to me, or the sexual abuse was my fault when I was 12, or so on and so forth. In a systematic way, helping people to understand and acknowledge those kinds of thoughts and then challenge them through a set of different skills in order to help them see more 9 times out of 10 that their thoughts, which are so distressing, are actually not accurate, to challenge those thoughts and come up with something more realistic, such as, I was a child and even there was no way that I could prevent what happened to me. That kind of a thing. And then there's some other anxiety management strategies. So CBT for PTSD is a time-limited therapy, highly effective. It's great. If you have just straight PTSD, this is wonderful. It works great. However, all these studies that have done all this work over the years to show that CBT is the treatment for PTSD, unfortunately has, had a lot of exclusion criteria. And exclusion criteria is when you're doing a study and you say, well, if you can be in the study if you have X, Y, and Z, but if you have A, B, and C, you can't be in the study because we have to have kind of like a pure sample to really be able to prove what we're trying to prove. That's what that means. So most of these kinds of studies in the past anyway have employed extensive exclusion criteria, meaning you can be in the study if you have PTSD and this, that, and the other thing, but you can't be in the study if you have psychosis, suicidal ideation, current substance use, cognitive challenges or impairments, frequent medicine changes in the past 6 months, et cetera. Now, who does that sound like? That sounds like exactly the client population that we work with. So over the years, by and large, most studies have excluded people who have psychosis and SMI. So we haven't been able to have them have the benefit of being able to participate in CBT and get the relief from that and see if it was effective. So that's a really unfortunate thing. And this is a pretty well-known researcher, and I think he said it best here when he says, true advancement of the field will require a deliberate process of evaluation and adaptation of efficacious treatments with less restricted, more clinically representative PTSD samples, like the clients that we're talking about today, basically. Because without that, what we're really saying to people is, sorry, too bad, all these treatments and all this effective stuff that we have, it's not for you because you're too sick to be able to get to participate in it. Like this cartoon says, I'm afraid there's not much I can do for you now. You should have come in sooner before you got sick. And we want to do better than that, obviously, which is why I'm here, which is why you guys are here too. Okay, so I just want to very briefly talk about interventions that have empirical support, that have evidence where research has been done on them to date for PTSD in people who have psychosis or SMI. So there's 3 main ones here. The first one I want to mention is exposure therapy and EMDR. You guys have heard of EMDR. Now, this is newer research. So, and this is done with people with psychosis. These are colleagues of mine. Two of them who are Dutch, and they've done some really good work with exposure therapy and people with psychosis. So it is now coming out that you can do that effectively. Now, this has only been done in the Netherlands so far in terms of like a big trial. So here we have different, a different health system, for better or for worse, I think mostly for worse, and not as many supports to our clients overall compared to the Dutch model. And so, I think we'd have to do some more research to see if exposure therapy would be okay. But I put that on there because it is starting to definitely have some good empirical support. The next 2 I want to mention are studies that my colleagues and I have done, or interventions that my colleagues and I have developed and have done a lot with. The first is cognitive restructuring for PTSD and SMI. And this is one that is based on the cognitive restructuring model that I mentioned a little while ago. And actually, for the past several months, I have been working with some of your colleagues in helping to train them in this treatment model. And there are 4 of them who are trained in it. And I believe all 4 of them are available, or most of them, hopefully, are still available to offer the intervention to your clients. I'm not working with them directly anymore. Our consultation ended. But these 4 people know how to do this intervention and know how to screen their clients for it. And so that is something to look into. And I think, if you want to seek them out, Sarah Kapelovich can direct you to them later on. So that's one of the interventions. It's 12 to 16 weeks, meeting once a week, and focus on cognitive restructuring, and it has been shown to be quite effective, which is nice. And then the second one is called Breathe, and it's a shorter intervention. And it's actually, when we did the study, we compared these 2, but Breathe was sort of our control condition. Like, we didn't think it was going to actually do anything, but it did. It actually was effective. And so not quite as effective in some ways as the cognitive restructuring, but it offers a really nice alternative because it's short. It's only 3 sessions, and it's not as comprehensive, and it doesn't include cognitive restructuring, but it's an alternative that we're just starting to do more work with and roll out in certain places. And it can be helpful for clients as well. And so what we've done to modify treatments, or in developing these treatments and rolling them out, is some modifications to help them be more useful and effective with this population. And so some of the things that we've done we've eliminated the exposure components. Again, not because exposure is bad. It's a highly effective treatment, and it can work really well, but because exposure is really hard. If anyone who's on this webinar has ever delivered exposure therapy or participated in it, themselves, they know it's grueling. That's kind of the point, right? You got to let it all hang out. And it's hard for clinicians to manage that or to feel comfortable managing that with people who have serious symptoms, serious mental illness symptoms. It's also hard because of how difficult exposure is. Clients drop out of it a lot, even clients who don't have SMI. And so something that doesn't have exposure, our philosophy was that it might, or in many cases feels more comfortable to participate in and to stick with, both for clinicians and for clients. It's a little less anxiety provoking potentially, and allows for more clients to participate in it. We've simplified the strategies for teaching skills in terms of teaching the cognitive restructuring and teaching the anxiety management skills, making it more palatable for people who might have cognitive limitations or impairments, or people who are, having concentration difficulties related to psychotic symptoms or thinking straight, that kind of thing. We've emphasized close coordination with the treatment team, so the treatment team is all involved in the intervention. Even though there's only one person delivering it, the treatment team is on board and knows how it works and can kind of support the client going forward. And just some basic increased flexibility to attend to the needs of clients. So that's just a brief overview of what's possible and what's been effective that we've developed and done a lot of work with people who have SMI and PTSD. And again, at North Sound, there are some clinicians who have been working with the CR, or the cognitive restructuring intervention, which is great. Okay. All right, let me, I'm just being mindful of our time here, and I'm going to move to our summary. So we talked about a lot today, and you could tell by the successive hoarseness of my voice how much we've talked about. And, just these are the things that I kind of want you all to sort of take home here. That trauma and PTSD are super prevalent in people with a serious mental illness. It's underdiagnosed, it's undertreated. Because it's undertreated, it has numerous negative consequences, but there's a way to screen that's brief and effective and useful. And there are some good interventions out there that once you've been able to screen and diagnose someone with PTSD, that can really make a difference in their lives, and that's really important. In thinking about next steps for you all, again, I don't know what the deal is going to be going forward with you all as far as referring clients to our 4 trained North Sound clinicians, or if or how your group is going to be doing screening with clients. So I can't speak to that, but what I can say is some important next steps that I would suggest based on what we talked about today is starting to consider conceptualizing your clients through that trauma PTSD lens as we did today, to better kind of understand what they're going through and what they've gone through, and to better, not that you're not empathizing with them, of course you are, but when you see things, some of their behaviors, some of their problematic behaviors, some of their unhealthy behaviors, some of their difficult interpersonal behaviors that impact you, when you see that more through a PTSD or trauma lens, it really does help to kind of increase empathy and hopefully sort of increase the quality of the working relationship. Not always, but we do what we can, right? So that's the one thing, is to look through this lens as you're thinking about clients, both new clients who come in your door and also ones that have been around for a while, who you've worked with for a long time. And similarly, continuing to check and challenge some of your thoughts about trauma and PTSD in your clients. And that's a really important ongoing exercise for us to do as psychologists and mental health professionals. And then, related to what I talked about before, talk with your program directors and your supervisors about potentially implementing a more system-wide screening for your clients. And also, as I mentioned, talk with your program directors and supervisors about referring some of your appropriate clients to the CR for PTSD treatment via the 4 colleagues of yours who are now trained in it. Here's some additional resources, resources in terms of like papers and chapters and things that talk about some of the things I talked about today. So thank you guys so much. I don't have any other new information to present at the moment. I think we have a couple of minutes probably for additional questions that you might have. And then I think we'll be moving on to some notices or information from Sarah, and then an evaluation.
We're gonna go ahead and open things up to Q&A portion. We have about 15 minutes. I know several came through and were addressed throughout the webinar, but if folks have additional questions, this would be a great time.
You guys all asked some really excellent questions throughout, so I really was happy to see that, because I think, you know, you all are really thinking about this from the perspective of your own clients and the work that you do with them. So I think that wow, we really did a lot of Q&A already. So there might not be a ton more, but please type in if there are. Oh, someone did ask, and I think I scrolled past it accidentally because so many things came in at once. I think someone did ask about access to the slides that I presented, and yes, you will be able to be sent a copy of those. I have the latest version that I will forward on to Sam, and I believe she will make those available to you.
And if folks do have questions, feel free to just unmute yourselves and ask, or you can type it into the chat window.
Yes. And I'm just going to scroll through while I'm doing this to see if there's any big ones that I missed. Okay, one thing that I see here that I didn't quite, I think I addressed a little bit, but someone wrote in and asked, a client has multiple traumas, which one of them to start with? I think that's why the screen, and I think this question came in before I started doing the screening teaching, potentially, but I think that's why the screening's so helpful, because it really, in a very objective, simple way, helps you to have the client kind of guide somewhat, at least, which trauma is the focus, or which is the one that's causing the most distress, or which is the one to talk about in the context of PTSD, because after they do the TLEQ and they have multiple traumas, they're asked to choose which is the most distressing one. And sometimes it's hard for clients to decide. They might go, oh, they were all terrible, they're all distressing. And the way to address that can be something like, you know what, I completely understand. And by me asking you to choose one is in no way minimizing anything else you went through or minimizing the impact of these other ones over the course of your life. That's totally understandable. I think what we want to do, though, is find out which is the one that's getting to you the most now. Because, you know, what we can potentially help with as a treatment team is helping you cope with stuff that's currently happening in the here and now. And that's sort of the best way we know to be able to help you. So if you had to, you know, if you had to pick one that's really getting you the most, or maybe, you know, combining two they're kind of equally impacting your life, you know, which one would you pick? And that's a way to sort of help narrow it down a little bit to help it not feel overwhelming for the client. So hopefully that helps to answer that question a little bit. So everyone might be a little questioned out, which is totally understandable because everyone asks so many good questions over the course of the 2.5 hours. So that would be understandable if there wasn't much left at this point.
We have a question that just came in from Elizabeth. Can you speak briefly a bit more about Breathe, the Breathe intervention?
Oh, yep. Okay, yeah. So Breathe is kind of a mini sort of version of the CR intervention, but it doesn't have CR in it. It's 3 sessions, and it is basically a combination of screening, monitoring of the PTSD symptoms by re-administering them across the course of re-administering the PCL across the course of the 3 sessions. And it involves a combination of psychoeducation about PTSD combined with worksheets and handouts to help the client personalize their experience. It does not involve retelling of the trauma or details of the trauma, but just a way to help the client understand what PTSD is and how those symptoms have personally manifested based on what the client's index trauma was. And it also includes some teaching and pretty intensive practice of a very specific breathing relaxation, breathing anxiety. I wouldn't say relaxation per se, that's often comes off as a weird word, but kind of a breathing anxiety management, PTSD symptom management skill. So that's what Breathe is.
I wonder if you could say a word about, we know that substance use is a big issue in individuals, both with SMI and with PTSD, as well as, when both of those conditions are present concurrently. And is there a sort of protocol or suggestions around when a client is using in terms of engaging them in treating the PTSD?
Yeah, so I can speak about that in terms of our own interventions, but probably not beyond that. So for our cognitive restructuring intervention and for our Breathe intervention as well, actually, when we did some of our initial studies in it, we had our own inclusion and exclusion criteria that you have to have when you do a study. And because other studies tended to exclude substance use, people who use substance use from being a part of their study, we wanted to be more inclusive because, as we know, and as you just said, Sarah, it's so prevalent in people who have SMI that to exclude people who suffer from it, especially people who have PTSD and SMI, then you're really narrowing it down to like 3 people who would be eligible for the intervention. So we really wanted to be more inclusive of that. And so the way that we did it was, and now the DSM criteria is a little different, but back in the day when we were doing this, it was if someone had substance abuse, like a substance abuse diagnosis, then they could still absolutely participate in our interventions, and it worked well still. If someone had substance dependence, kind of that more severe end of the continuum, that where they were unable to maintain any periods of sobriety and needed a higher level of care or detox, then we held off on having them participate, because the fact of the matter is, in order to have these treatments work, the person, because they're so skill-based, we're trying to teach the skill and we're trying to have people practice these skills fairly intensively on their own, they need to be able at least to be in the CBT sessions while they're not under the influence, and when they are on their own between the sessions, be able to be sober or not under the influence while they are practicing the skill. So it's not like we're saying to people, you have to quit using substances entirely to be in this treatment, but what we are doing is working with the client and the treatment team to see if we can find a way that if the client is having difficulty with substances, we can kind of negotiate with them and they can feel comfortable with the idea of like, okay, I get it. When I will come in for the treatment sessions, I will not be under the influence, and when I practice the skills, I won't be under the influence. And oftentimes that takes a lot of negotiating and work and sort of trying to be flexible enough with the client to go, okay, I know you tend to use more in the afternoon. What if we scheduled your appointment in the morning? Would that reduce the likelihood that would that increase the likelihood that you would be able to get yourself in and we'd be able to work together effectively? Or conversely, I know you tend to use late at night, we should probably make our appointment later in the day to give you more chance to sort of sober up so that you can come in and work well with me on these skills. So that's kind of how we used it, and we would monitor it in the longer intervention, the CR intervention, if someone had substance use difficulties, it would just be on the table a lot. How's it going this week? What have you noticed as far as, your PTSD symptoms and how that interplayed with the amount that you drank, for example. So there's a lot of ways that we kept it on the table because it's really important.
And then we had another question come in through chat from Rachel. Just curious if you have any recommendations on books or articles to read on this topic that would be helpful next steps for us.
Yeah, I would say that on my last page of my slides, there's a list of articles that talk in more detail, some of them more clinical in nature and some of them kind of a mix of clinical and some research that really talk in detail about this kind of thing. There's also a book that my colleague Kim wrote with some of my other colleagues. It's 10 years old now. Is that true? Wow, I think it's from 2009. So, but it's a great book still. And that is called, actually, hold on, I have it right here. I'll hold it up. Hold on. Okay, I feel like I'm doing a commercial. This is called Treatment of Post-Traumatic Stress Disorder in Special Populations by Kim, Stan, and Harriet. And this is a good book. This might be a little much for what you're looking for, but it's good in that it really sort of conceptualizes a lot of what I've talked about today and has some good case examples. So that's a good one. Okay. I see here, are these screening tools available in other languages? So the PCL is, except that the PCL is a new version now. It used to be the PCL-4 for many years that corresponded with the DSM-4. Excuse me, but then, DSM changed from 4 to 5 and it changed some of the criteria for PTSD, as we talked about earlier this morning. And so as a result, they made a new PCL, and that took a while to create it and to validate it and to study it. And so they do not have it in Spanish yet, but I know that they're working on it. So the most recent version is not available in Spanish yet, as far as I'm aware. And for like Latin American Spanish. So hopefully that's coming up. There's been a lot of research on the PCL. You can learn more about the PCL if you go to the National Center for PTSD website. They're the ones that developed it. They do all kinds of PTSD education and materials and so forth. So that would be a good thing to check out if you're interested in learning more about PTSD. Now, it's not specific to SMI, but it gives they provide a lot of good information about PTSD in general. And the thing about the PCL is that the PCL was not designed for people with SMI per se. But in the studies that we've done and some of our colleagues have done using the PCL, we found that it actually works pretty well with people with SMI, and that the questions feel valid, and that it's reliable, and that it gives us the information that is accurate, and that it's easily kind of used and understood language level wise for people with SMI.
So Jen, thank you so much for joining us for the morning here in the Pacific Northwest. And we wish that we could bring our 50-degree weather to you.
Oh, I wish that so much. You have no idea. I shouldn't complain too much. At least I don't live in Minnesota, but it's not pretty here either. Yeah. I know, I'm jealous of your weather. It was my pleasure. Thank you guys for participating. I know sometimes from a distance it's a little challenging with the webinars, but I really appreciate everyone's participation and questions. And Sarah and Sam, thanks for setting this up.
Thank you. Take care, everyone.